Hello and welcome to my video about the stages of physiological birth and some of the common signs and symptoms we expect to see with the mother telling us what stage of labor and birth we are at and what we might feel as far as dilation and fetal presentation. We're going to be talking about anatomy, physiology, the movement the baby makes through the pelvis to be born, which are generally known as the cardinal movements. All the pelvic planes, all the common places dystocia can happen, and some of the ways to avoid those dystocias. We're going to be talking about the 4 P's: passage, passenger, powers, and psychology. I just want to mention it's important to note that we have freedom and patience in an out-of-hospital birth to work with the baby and the body in ways that may not be possible or permitted in a hospital birth. Midwives tend to cultivate skills that are not used by physicians any longer, since they have so many tools at their disposal which do not require the use of skills that have been used for time immemorial. Shortly put, as Claudia always says, midwives know how to get a baby out. And that is so very true. I'm going to start by briefly describing the planes of the pelvis. The pelvis has been divided into 4 key planes to help us describe different anatomical structures and describe the movement the baby takes as it passes through the pelvis to get earthside. The planes of the pelvis are as follows. The plane of the pelvic inlet is up here at the top. It extends from the sacral promontory right here to the superior pubis symphysis, which is right there. The plane of greatest pelvic dimension, which is kind of mid-cavity. The largest, most spacious area, as we can see, extending from it's kind of easier if I tip it, from the middle of the sacrum, S2 or S3, right about there, to the posterior surface of the symphysis pubis, right about where they have this weird knobby thing on my pelvis to hold the pelvis together. The plane of least pelvic dimension, which is the obstetric outlet. This is the narrowest part of the pelvis, stretching from the tip of the sacrum down here to the posterior surface of the pubis symphysis, which is right here. And then the anatomical outlet is the inferior opening bounded by the ischial spines, the coccyx, and the pubic arch. So as you can see, some parts of the pelvis are much tighter fit than others. For example, you can see the obstetricial outlet is pretty tight. To accomplish movement through these tighter planes, the baby has several things going for them. For one thing, the bones of the baby's skull are not yet fused. So it's important to know that. The fetal skull at term consists of primarily 5 major unfused flat bones. Well, they're not really flat, they're curved, but that form a vault. We got the frontal bone, 2 parietal, and 1 occipital. And they are connected by membranous sutures and fontanelles that allow for compression and molding as they go through the birth canal. I created my own sutures and fontanelles on this doll. Didn't turn out great, but I did an okay job on that. While the entire skull comprises more parts, these 5 key bones are critical for labor. And it's also important to understand that the outlet of the pelvis is deeper than it is wide. I think you can see that it's deeper than it is wide. And the inlet is wider than it is deep. So obviously this creates a situation where the baby is going to have to move to get through these spaces. This is why most babies will enter the pelvis in a slightly asynclitic presentation, which means their head is going to be a little bit tilted just to fit in between that sacral promontory and front where the sympathus pubis is. So yeah, the baby has to kind of wiggle its way in, as you can see, and tilt its head somewhat. It's also important to note that although the baby most definitely helps move itself through the pelvis, the power of the uterus contracting and pushing down on the baby pushes the baby down into the place of least resistance. And it's also important to remember, it's kind of hard to visualize sometimes when we're talking about the pelvis, but it's important to remember all the layers of tissue, ligaments, and muscle that are in here as well. So it's not just a straight passage. There's definitely pelvic floor, a lot of things going on here, the bladder, things of that nature. So there's a lot for the baby to navigate. That's why it's really important to make sure mom is peeing often, emptying that bladder, because that's going to make more space. And anything we can do to make more space, because as you can see, even once you add in the muscle and the ligaments and all of the tissues that are in here, you're not left with a lot of space, but there is a lot of things we can do that creates more space. And one of those things is like advocating for the mom to constantly be peeing. And the mom's pelvis, we have to remember, is amazingly malleable as well. Not just the baby's head, but the pelvis. The mother's pelvis is comprised of 4 main bones. We got 2 hip bones up here. We've got the sacrum, the coccyx, and we got the iliums, the ischiums, and the pubis. And as you can see, there are joints. There are joints between these bones, which allow for a lot of flexibility and movement. And because the mother has been getting hormones throughout most of pregnancy, like relaxin, that helps to soften and loosen these joints, she will feel very unstable at the end of pregnancy, and it might even hurt when she's walking. I felt a lot of pain in my sympathus pubis when I was walking at the end of pregnancy. However, it definitely helps to facilitate birth. So it's good to remember that. And there are also stations that were developed years ago and designed to help us understand like where the baby is. If we are doing internal exams, we can feel where the baby is at. And even from the outside, you can kind of tell when the baby, where the baby is at to a degree. It's much easier, obviously, through the inside. So the stations are like thus. You get up here at the top is +5. -5. I'm sorry. I'm reversing them. And down here at the bottom is the +5. I heard a labor delivery nurse once say, +4 or more is on the floor. So that's how you can remember which one is plus and negative. Negative is up here, plus is down here, because the baby is finally being born. And the midline of the pelvis, right around the ischial spines, is where we're going to call it 0. So right about here is 0. We got +5 out here, +4, +3, +2, +1, 0. And then you go back this way. -1, -2, -3, -4, -5. So that kind of can give us some indication. That's called station of where the baby is at. So it just designates where the baby's at when we're talking about moving through the pelvis. I heard the pelvis once described by Nicole Morales in a lecture I was listening to as a funnel that the baby must progress through. And I thought that was a really good visualization. As soon as I heard that, I kind of understood a lot better. I'd tried to study the Cardinal Movements previously, but as soon as I heard it described as a funnel, it made a lot more sense to me, because when you think of a funnel, it's getting smaller and smaller as you're going down and down, right? And a lot of times liquid, fluid, whatever's moving through the funnel kind of has to turn to get through. A lot of times you'll see a lot of movement like that. And that is kind of what the baby is doing, because as the baby is bumping up against different bony structures, they will turn to the path of least resistance. They also move like water. You might want to think about it as water in a stream. It will always take the path of least resistance, and it's true for babies too. So I like to think of the pelvis as kind of like a funnel shape, and the baby will do a series of movements down and out to get out. We call the pelvis the passage, as it's the route that the baby must traverse to get earthside. The baby is an active passenger in its own birth and is quite intelligent and deliberate in their movements. They will follow the path of least resistance, which generally leads them into a well-flexed, good position for birth. We know lots of movement during labor and position changes will help the baby to find the right way into the pelvis and to the path of least resistance. And experienced midwives will say that giving mom lots of tools, such as birth stools, hanging things to hang from, squatting bars, balls to roll on or bounce on, peanut balls to put between their knees in the bed, will help them find the position that will work best to facilitate getting the baby out. And there are a lot of things we do before we even get to the point of birth that are going to help facilitate an easier passage. I think one of the biggest things by far, which I don't think talk about enough in midwifery school, and we definitely have somewhat this semester, is the relationship that we build with the mother. And, some people, that might sound like woo or kind of silly, but if you've read anything by Michelle Odant or Susan Buckley, the researcher in Australia, you know that facilitating trust between ourselves and the birthing woman is much more important than I think we can even grasp. It seems to me that we've created an environment, and it's kind of hard for us to grasp because we have such a mechanistic sort of world. And especially how we view birth often is so mechanistic that we focus on, the movements of the pelvis, and we're focused on, the diameters, the measurements, the planes, and we don't think about the hormones that play into it and how fear or just, not feeling right or not feeling ready for birth can really play a huge role in facilitating just a wonky birth, dystocia. So I think that's something we don't talk about nearly enough, and I hope to incorporate some of Michelle Odant's practices into my own practice, because I think building trust with our people and really having an established relationship with them really helps a mother feel safe when it comes time to give birth, which is incredibly important to releasing the hormones necessary. We know adrenaline really tamps down birth and can turn off the hormones that are needed to create a safe and healthy birth. So, there's been numerous studies about this. Susan Buckley especially talks a lot about oxytocin and how if you are in an environment where you feel unsafe, the oxytocin isn't going to flow, and oxytocin is really what creates the contractions which bring the baby. So, I think one of the best things we do, one of the most, maybe overlooked interventions that we do ahead of time is create a safe environment for the mom by spending an hour with her. For months and months and months, we're spending an hour with her, like at first, maybe once a month, and then down to once a week. And we just really get to know her. We get to know her hopes and dreams for the birth. We get to know her partner. We get to know, what makes her feel comfortable, what makes her feel safe, and then we can facilitate those things. And I think that honestly is one of the best tools, one of the biggest tools that we don't maybe use as much as we could or should. So yeah, it's super important. Because if we look at any other mammal in the world, when they want to go to give birth, they will generally hide, and they hide because they want somewhere that feels safe. They don't want to be disturbed when they're giving birth, and we have the opposite of that with the majority of births in our culture. It feels very disturbed. There's like strangers coming in, lots of noise, lots of light, etc., etc. Cold. It feels cold. It feels sterile. This is not the type of environment that moms want to give birth in. And I think this is kind of, in some regards, it's gone too far. Like, people think that the magical setting is all there is to birth. And in another regard, we're not really thinking about how facilitating safety is what gets a baby out. So it's important to note that most babies will enter the pelvis with their heads. This is called a cephalic presentation, and that's good because there are a number of things that can happen with breech when they enter with their bottoms. That is not so ideal. So the head is really the ideal way to be born. The head of the neonate is uniquely suited to come first as the baby travels to the outside. As we talked about, the neonatal head is designed to be somewhat malleable. Most people have heard of baby's soft spots. The fetal skull bones are not yet fused, like we talked about. And so they smartly are made to slide over each other, making the dimensions of the fetal head somewhat smaller to fit through the pelvis. This is called molding. A neonate can be born with quite a misshapen head, which will become round again, usually in a number of hours. It's kind of amazing. When you're packing them up to leave for the birth, the baby's head will look very different than when it was first born, which is kind of incredible. The first cardinal movement is called engagement. It can happen weeks before birth, as in with multiparous women usually, or during early labor. So it's really very variable. Engagement looks like the baby coming down to meet the pelvis, like this. It is said to be entering the pelvis. It's also described as lightning. You might have heard of lightning, because the mom has more space to breathe. The baby has dropped. Mom will begin to feel more pressure in her pelvis. It'll be harder to walk, but it'll be easier to breathe. So it's a kind of a trade-off. Yeah, you trade one horrible thing for another, I suppose. She might start at this point having mild contractions. She might start feeling like today might be the day, but this could go on for a number of days. So it's important to remember that it's not just because she's having contractions, it's not that day necessarily. So the body's getting ready. She might still be able to go about her daily tasks. She's talking with her friends and relaxing. There are some subtle changes starting to happen in the mom's body. Her hormones that kick off labor have started working in her body. She may start to notice some bloody show or even a release of her waters, although most labors don't start with release of the waters. Her cervix has begun dilating a little bit. Again, this could be days or weeks or hours before the birth will take place. So it's quite unpredictable. That's why the Friedman's curve makes me so nauseous when I look at it, because it really is so unpredictable how that will all play out. And again, with multiparous women, this process can start way, way, way before it would with, with someone who has not had any children yet. So, okay, where was I going? So her cervix has begun dilating, but it could be weeks, hours, or days before the birth. This is kind of the latent labor phase. I don't like the word latent there because it implies that like nothing is happening and there's actually a lot that's happening. But it's called the latent labor phase. Especially in primates, can be a while, but it can also be a while with the grand multips too, because their body is kind of tired. It knows how this process works, but it also has is kind of tired. And depending on lots of different factors, it can be quite a long time. So really just depends. It's very different. Every birth is so different. So especially with the grand multips that have had lots of births one after the other and not good spacing, maybe poor nutrition, the latent phase can take quite a while for things to ramp back up again. If a mom has a pendulous abdomen, it can be tricky for the baby to get in a good position or stay engaged because there's a lot of extra space for that baby to move around. Sometimes we say to wear like a belly belt, something to hold, to give it a little more, or bind the belly, something to hold it a little better, to give the baby a little bit more resistance so that when it comes into the pelvis, it stays in the pelvis. Because the pressure of the head coming down onto the cervix as well. You got to picture that the cervix is also in this pelvis. The pressure of the head coming down onto the cervix can also greatly help move things along. So keeping the baby well engaged, and they're less likely to end up in some wonky, entering the pelvis in some really wonky position that creates labor dystocias, excuse me. You can also tell a mom that has like a very pendulous abdomen to spend a lot of time kind of leaning back, which normally we would not recommend because that bad posture kind of can create a situation where the baby comes in a wonky way. But if we have a mom with a pendulous abdomen, that leaning back helps the baby to fall more into place. So we want her kind of off her sacrum, spending a lot of time leaning back, which is something I learned from Penny Simpkins' Labor Progress Handbook, which was probably my favorite book this semester. I learned a ton from that book. So anyway, there's a lot of positions we can use for a mom with a very big belly to help her baby get down and in the right position. And not just for moms with big bellies, but like any moms, we have lots of tricks to help the baby get where it needs to be. We are very skilled at accessing the outside or the inside and assessing where the baby is. It's not just about learning like this is the head, this is the bottom, and feeling those through the wall of the abdomen, although those are important skills as well. But we learn the skills of, if we're doing a vaginal exam, being able to tell which way the baby is positioned by what we're feeling with the sutures and the fontanelles. And we can also tell by where we're hearing the heartbeat on the outside of the belly, because as labor is progressing, we're constantly keeping track of that heartbeat, the fetal heartbeat, and as the baby moves down, so will the fetal heartbeat. Usually, there's always exceptions to these rules. For example, moms with a lot of fluid in their abdomens. I helped with a birth that the mom had just an incredible amount of fluid. You could hear the heartbeat. It was like echoing. You could hear almost like it echoing on the other side of her belly. So it can get thrown off by situations like that, but generally, as the baby moves down in the pelvis, the heartbeat will go lower and lower and lower. And once the baby's really well engaged, like coming out, you might even have a really hard time finding it because it's so low, and you're like pressing on the, you're on the bones you're on the pubic area, basically trying to get heart tones sometimes. So, yeah, but those are some of the skills that we utilize to find out where the baby is, how the baby's moving through the pelvis. We try not to do too many vaginal exams because we don't want to introduce bacteria to the vaginal area, especially if the the membranes are ruptured. Obviously, we keep our hands out of there as much as we can. But yeah, we have other tools to figure out where the baby is and how it's moving down. But the mother may also request internal checks, so we try to listen to that. If she is asking for internal checks, we do internal checks, because there's reasons. Again, we're working with her, we're not just working with her body as a machine and the baby's body, we're working with her psychologically, and if it's going to benefit her to know what's going on, then we do what she asks, because usually the mom knows what she needs, and she will ask that of us. So, and the next cardinal movement is called descent. So once the baby is engaged with the pelvis, the baby starts descending. At the same time, there's a movement called flexion, because as the body is pushing down on this baby, the baby's trying to take the path of least resistance, and it's hitting up against the pelvic floor of the mom, and that will create sort of tension, and the baby will start to flex. Its legs are going to be like this. It is trying to be as small as possible. And the way it brings its chin to its chest is really great, because the smallest diameter of the baby's head is now coming down into the pelvis. So that works really, really great. So we're hoping that the baby is in OP position. And this one is. So, the baby, the cervix is now opening more. It's going to be like 6 centimeters dilated maybe at this point. The baby's head is creating more pressure on the cervix, which is going to create, because of the the feedback loop, the positive feedback loop of hormones, the pressure on the cervix of the baby's head, which is causing it to open more, is going to create stronger and harder contractions, which is going to create more opening and more opening. And the more opening is going to create more pressure as the baby moves farther down. And the more pressure is going to create more release of hormones, which is going to cause more hard contractions, etc., etc. So as you can imagine, this positive feedback loop works really great. The baby is pressing on the pelvis, which is creating release of more oxytocin. The oxytocin is creating stronger contractions. The stronger contractions are pushing the baby harder. The baby pushing harder is creating more oxytocin. The harder pushes and the more oxytocin is creating stronger contractions, etc., etc., until the baby is out. Mom is going to be a little more internal at this point. She's not like laughing with friends or talking to everybody and, you know, gossiping and laughing and hanging out. She's more, definitely, while contractions are happening, she's going to be mostly focused. She's not going to want you asking her questions. Please don't ask her questions. Try not to bother her, touch her unless she asks for being touched. Like many women often do want a lot of touching when they're having contractions, and others don't want any at all. And some will, you know, want to be somewhere, you know, not with other people, kind of hidden away, like that cat we talked about, like that animal that is hiding in their secret safe place. Some moms are starting to do that. They're hiding away. But there's often also other moms that are going to want pressure on their hips or pressure on their back. Every time a contraction starts, they want pressure on those hips, pressure on the back, or their hand held, or just someone, you know, breathing with them, or, you know, some kind of rhythmic chanting, or, you know, stroking. Those are all very helpful usually during this cardinal movement. Or dancing or rocking. Those are all great ways that she can engage with and ride the waves of the contraction without it overwhelming her and overstimulating her. So I think we talked about flexion, which happens kind of simultaneously with descent. The thing is, they're kind of all happening simultaneously. So even talking about the cardinal movements as separate events is kind of tricky, because it's not like that. It's like all these things are happening at the same time. The cervix is dilating, the mom is laboring, the baby is moving, the pressure is building. All these things are happening at the same time. So there's flexion happening, you know, the baby's turning. It's all happening at once. So, but the next cardinal movement is internal rotation. So that baby is well flexed. It's down in the pelvis, and it's gonna start turning to get past those ischial, can you see? Past the ischial spines, which are kind of in its way. It might bump up against one of those ischial spines and start turning. So that is what the internal rotation is. She's going to be more dilated. The baby's going to be at 0 station at this point. It's kind of moving towards the roomiest part of the pelvis. The mom's going to be 9 to 10 centimeters dilated maybe. She's heading into transition. She might be shaking, crying, saying, I can't do this, I don't want to do this, just take me home, you know, any of those things that they might say. Moms that are tough and strong at previous parts of the labor are now sometimes brought to their knees by this part of the labor. So it's important to realize she's going to need a lot of emotional support to get through this point. But if you can remind her that she's almost, you know, towards the pushing stage, a lot of moms really kind of enjoy the pushing, not enjoy, but they like it better than the other stages, because they can finally do something with these contractions to help get that baby through. So they're not just waiting for everything to open, they're finally going to push the baby out. She might get fully dilated and then come to a stage called the rest and be thankful stage, which isn't even recognized really in most modern OB literature, or, you know, in hospitals, or, you know, in, what do you want to say? The way we do birth in most places, it's not really recognized. But I think it's important to really take advantage of that if possible. If she wants to, sometimes she goes to sleep. Sometimes she just has a few minutes to catch her breath and maybe eat a snack, get some water, you know, get powered up for the next part, which is going to be the pushing part. And I think that it's really sad that we don't take advantage of it in a lot of modern settings. And at this point, they would just say, you're complete, let's start pushing, you know, and coach the mom to push, even though maybe the pushing urge isn't there yet. So the rest and be thankful phase is another thing we have in our like midwife bag, I want to say. It can be really great to watch a mom like take a little nap, wake up, pushing, and then here comes the baby. And usually the pushing phase is real quick. I've seen moms just like totally have a good power nap, come out of it, and they're pushing, and it's really clicking along at that point. So I like that phase. And then the 5th cardinal movement is going to be extension. This is when the baby is kind of rotated towards the back at this point, and it's starting to, you're going to start seeing glimpses of the head extending out of the opening of the vagina. That is very exciting for a lot of people, for the mom, for the family. You can get a mirror and put it there so she can see the progress she's making and finally start to see the babies coming on the outside. Maybe she can reach down and feel the baby's head, which can be very encouraging to a mom, and just give her that strength to keep going. You're going to see the tissues starting to bulge. The baby's head is going to be all there in the perineum. So you're going to see everything is bulging out at this point. You might just see, you know, just the smallest amount of the hair or head, but you're going to see the bulge of the baby's head. And then you know that this is happening for real. Eventually the head is born with a gush of water sometimes. Sometimes a gush of fluid. Now the baby's at I'd say +4. And yeah, sometimes then the mom's gonna take a deep breath. Again, there's gonna be just a little break, but you don't want too long of a break, because if you're seeing the baby's head just staying there and staying there and staying there, you might have a bigger problem, which is called shoulder dystocia, which is when one of the baby's shoulders is impacted on the pelvis, which is a real problem. Can be super tricky to get out, but midwives have tools for that too. I've seen one shoulder dystocia so far, and thankfully it turned out fine, but it was real scary for a minute there. Definitely went home and cried. But yeah, there are ways to get the baby out. You can flip a mom to all fours. I don't know if you saw, but as soon as I flipped the mom over, the baby's head you create some more room. Or you can put her in a running lunge, like a runner's lunge, like you're stretching before a race. You try one side, then you try the other side. There's suprapubic pressure that can be done. There's a lot of things that can be done. But shoulder dystocia is definitely one of those emergencies where you don't want to wait to see what will happen. If you're seeing shoulder dystocia, you start acting on it. You make a phone call to 911. You get somebody coming, even if the baby is out by the time they get there, which is what happened in the case that I'm talking about. And everything was fine. The baby was totally, by then, the baby had been resuscitated, was on mom, ready to nurse, and the EMS said, "What are we even doing here?" And we said, "Oh, we just wanted to make sure, we had a shoulder dystocia. We wanted to be cautious rather than, have some issues." But yeah, the baby had already been resuscitated, was breathing well. So that's another thing. If you start seeing a baby getting stuck, immediately get ready for a resuscitation. If you don't already have, if you have a resusc cradle, if you don't already have that out, get that out. If you don't have your oxygen out, get the oxygen out and set up. Have somebody make a phone call to 911, because that is a scary emergency. Hopefully I don't see a lot of them, knocking on wood. I know I'll probably see, maybe another one, two, or I don't know how many. It really depends. You can't predict. Shoulder dystocia is one of those things that it's impossible to predict, who it's going to happen to. Because the literature is saying things like, oh, it's going to be, the woman with the large baby, the gestational diabetic baby or something. The one we saw looked like it was a normal sized baby. The mom was a normal sized mom. I'm not really sure why we had a shoulder dystocia. It's really hard to predict. So her belly looked ginormous on her, but the baby wasn't really that big. I don't know, but so it's impossible to predict. So you have to be ready for that. And it's important to remember that shoulder dystocia is not a soft tissue issue. Claudia really made a point of telling us that over and over again, because the literature, even in Penny Simpkins' book, I was so disappointed to see that they were cut an episiotomy. But it's the shoulder that's stuck with the baby. So if you think about it, cutting an episiotomy down here in the perineum isn't going to help that stuck shoulder. It's bone against bone. It's not that the perineum isn't going to stretch, because it's probably stretching just fine. It's not the perineum at all, usually. If it is a perineum issue, it's not shoulder dystocia. It's something different. So then you got a different problem. And according to Claudia, if the perineum, the reason you would cut the perineum is if the perineum is not going to stretch and it's just going to explode or tear very, very badly. And you can see that you cutting it would prevent a terrible tear. Then that would be a case where you would want to get out your episiotomy set of scissors. But that's going to be a rare one. And that is a different issue than shoulder dystocia. So I think it's kind of strange that those two get kind of pushed together. But The 6th cardinal movement is going to be internal rotation of the shoulders. So the baby's head has come out. That. And the shoulders, you're going to see the head on the outside turn. And the shoulders inside are also turning. This baby's being stubborn, but... And I want to note here too that it's important to note that breech babies also have their own movements that they go through, and they are similar, but it's not just reverse of a cephalic baby. It's like a different set of movements that you're going to see. But it's breech baby. I've been to one breech so far too. It was a surprise breech. What a surprise. And I drove like 100 miles an hour to get there because my preceptor called me while I was on the road and was like, "Oh, we got a breach." And I was like, "I want to see this. I really want to see this." So, thankfully, no speeding tickets, but yeah, I did get to see a surprise breach. And this one did it very textbook, so I got to see those cardinal movements of breech, but it is different. It's not just the opposite. It's not just backwards of what we expect with the cephalic baby. So that was fun. But yeah, breech is its own thing. I don't really have time today to talk all about breech. I was born vaginal breech, so I was really excited to see that vaginal breech because I got to see what my birth kind of might have looked like. I mean, it was probably different. I was in the hospital. This woman was at home, so there was a lot that was probably different. But so the 7th cardinal movement is expulsion, the birth of the baby. Yay! So the baby's head's out. It's restituted. Turn back, and then it comes expulsion. The baby comes out. So, the birth of the body. The babies can be born in almost as many positions as a mother can get themselves into, although standing on your head might not be most ideal. Midwives favor working with gravity, so you can we prefer upright positions. And those have been shown to create a lot less tears usually too, so that's good. Tissue just works better with an upright position and a downward head. So, you know, I've seen standing, leaning on the bed with a pile of pillows. I saw a video of a woman just standing in her backyard and didn't even have anybody catch the baby. The baby came out, hit the floor. I hope it was okay. That was a weird German video. But anyway, standing, you know, leaning over a bed or something, or a couch, whatever you want to be, squatting, either on a birth stool, supported by a partner, dangling squat, in a birth bed, on the toilet, hanging from the ceiling, on all fours, side lying, semi-reclining in the bed. All these and many others are appropriate positions for birth. We don't discriminate. We let people birth how they like to birth. And it really does help. It does seem like moms just intuitively know that that what their bodies need. They know what positions to get into, to get that wonky hip, to move. They've been moving with this body their whole lives. I think that's the thing that we really need to remember, is like they've been using this body their whole lives. And if they can feel on the inside something's pinching, something's, you know, there's pressure, they can move in certain ways to make more space there for the thing to get through. So don't forget, movement's our friend. I like that Claudia constantly says too that we don't want to force the mom to move if she's already doing what is working for her. It's detrimental to have a doula coming in or whoever and just start, you know, coaching the mom to move when she's already doing something that's working for her. I had an Amish birth with a first-time mom that spent hours on her hands and knees, just like doing a big circle on the floor, crawling on her hands and knees, and just like growling loudly and kind of grunt. I mean, it looked like an exorcism if anybody walked in, and it made me feel a little uncomfortable because as a doula, I've been taught, you know, there's all these things we can do, and I wanted to move in and interfere, but I realized that that was what that mom was working with and needed to do. And she honestly had her baby like really quick for a first-time mom, so it worked for her. And so we don't want to disrupt those things. But her poor knees, she must have the sorest knees after all that crawling and growling. But yeah, when the baby was finally actually coming out, she used a birth stool. She pushed like, I think twice, and the baby came right out. I think all that movement had just created a dynamic where, whoa, oh, I broke my pelvis. It was a cheap one from Amazon. What can I say? All that movement had just really like helped facilitate that birth. And that is what we want. We want, as you know, as intervention free as possible. So when we see a mom working with her body in that way, we do not interrupt them. We let them do the work they need to do to get the baby out. And then we catch, and all is well. And that makes our job really simple. So we want it to be as simple as possible. Most time we do not want to create interventions if we can help it. So yeah, that is it. That's my Cardinal Movements. I hope you enjoyed it. It was a little bit scattered, but there you have it. That's what I got for you. Thanks. Bye.